A 70-year-old male presented with headaches and new-onset seizures. MRI studies revealed a 3-centimeter enhancing mass in the right parietal lobe. A craniotomy was performed. We were called for an intraoperative consultation. Smears and frozen sections were prepared, both of which were stained with H&E. We will begin with the smears. This is a low-power view that shows a hypercellular population of lesional cells. A higher-power examination shows clusters of cells with scant cytoplasm and evidence of nuclear streaming. The tumor cells have ovoid to irregular nuclei, relatively even and coarse chromatin, frequent apoptotic bodies, and nuclear crush artifact. Cells that have more cytoplasm are less susceptible to nuclear crush artifact during the preparation of the smears. The presence of crushed nuclei is therefore a clue that we are dealing with a so-called blue cell tumor. The term small blue cell tumor is often used. However, in many cases, the tumor cells are not actually small. We do not measure the size of the nuclei in most cases. Rather, we compare the size of the tumor cell nuclei to background normal cells, such as a mature lymphocyte. A mature lymphocyte has an average nuclear diameter of 8 micrometers. Although there is no standard definition of a small cell, a mature lymphocyte can be used as an approximation for what is considered to be small. In this case, our main differential diagnosis is between a high-grade glioma, metastatic small cell carcinoma, and a lymphoma. One of the main clues is provided here on this cytologic preparation. Look at the background in between the tumor cells. Gliomas will have thin threads of cytoplasm that will impart a fibrillar background. This feature is lacking in this case. Lymphomas will have a dirty background with abundant blebs of cytoplasm, which are referred to as lymphoglandular bodies. This feature is also lacking. Almost all CNS lymphomas fit into the category of a diffuse large B-cell lymphoma. The tumor cells in a diffuse large B-cell lymphoma will have more conspicuous cytoplasm and multiple prominent nucleoli. Notice the lack of prominent nucleoli in this case. Based on these features, we are leaning toward a metastatic small cell carcinoma. Now let's look at the frozen sections for another important clue. The frozen sections show cohesive nests of malignant blue cells that have a circumscribed border from the surrounding brain tissue. Such a circumscribed border is an important clue that further supports this as a metastatic tumor. Infiltrating gliomas will characteristically blend into the brain without evidence of a circumscribed border. We made a diagnosis of a metastatic small cell carcinoma on the frozen sections. The permanent sections show a population of malignant cells with irregular nuclei, scant cytoplasm, frequent mitotic figures, and apoptotic nuclear debris. Notice that the tumor cells have elongate and somewhat carrot-shaped nuclei. Importantly, the tumor cells lack prominent nucleoli. This helps to exclude a diffuse large B-cell lymphoma and a large cell neuroendocrine carcinoma. Immunohistochemical studies are performed. The tumor cells are immunoreactive for cytokeratin 7. Notice the unique dot-like pattern of expression adjacent to the nucleus. This is referred to as a Golgi pattern of expression and is a feature of neuroendocrine carcinomas. The tumor cells are strongly immunoreactive for synaptophysin and TTF1. These findings support this as a metastatic small cell carcinoma of lung origin. In this case, the patient did not have a known history. After the craniotomy, the patient was scanned and a lung mass was found. Now for some questions. Which molecular alteration is most commonly associated with small cell carcinoma of the lung? The correct answer is C. TP53 and RB1 inactivation. Small cell carcinoma rarely presents with EGFR mutations or ALK rearrangements, and currently there are no known actionable mutations for this type of lung cancer. TP53 mutations are present in around 90% of cases, while RB1 mutations are present in 80 to 100% of cases. Additionally, P10 mutations are present in 15 to 20% of cases. Which immunohistochemical marker is typically expressed in small cell carcinoma of the lung, aiding in its diagnosis? The answer is A. Thyroid transcription factor 1, TTF1. These tumors are often positive for cytokeratin 7, but this is a less specific finding. In the context of small cell carcinoma of the lung, which histologic feature is considered characteristic of this malignancy? The correct answer is cells with scant cytoplasm, nuclear molding, and frequent mitoses. For some cases, it may be difficult to distinguish between a small cell carcinoma and a large cell neuroendocrine carcinoma. Small cell carcinomas will generally have a diffuse growth pattern, scant cytoplasm, and nuclear molding. Large cell neuroendocrine carcinomas are more likely to have a trabecular growth pattern. Additionally, the tumor cells have more abundant cytoplasm and prominent nucleoli. This concludes this case of a metastatic small cell carcinoma to the brain.